All right, how's everybody doing? It's Dr. Omurtag back again. This is the Asherman's video series talking about the treatment of Asherman syndrome. So or again, uterine syncytiae, depending on the severity. So again, if we have on one end of the spectrum Asherman syndrome, which is where an entire cavity is obliterated, is on the extreme side, and then on the less extreme side is maybe an area, uterine syncytiae, is present, so maybe one or two bands of scar or adhesive disease, and that's it. What I have outlined here is the approach. So as I talked about in a prior video, in order to set expectations about the extent, or to at least measure the extent of any scarring in the uterine cavity, a saline infusion sonohysterography is usually the first line testing, which is again a vaginal ultrasound where we instill saline and then we can assess the extent of scar in the cavity. Here I have a top-down view of the uterine cavity, a distended uterine cavity, and here's a side view. This is normal. The blue is, if there's any scar here, here's just one syncytiae band. Here's, again, this section that is obliterated. This would be kind of like a side view of that, okay, roughly. So the approach to treatment is usually an outpatient surgical procedure called operative hysteroscopy with lysis of adhesions. Hysteroscopy is the passage of a camera without any incisions through the cervix into the uterine cavity. We can pass scissors through a hysteroscope so that we can cut through any scar and open up the uterine cavity. So in this scenario, for example, we would do hysteroscopy. We would go in, we would cut and open up until we can see the opening to that right tube so that the finished product looks like this. So where you have some remnant of the scar up here, but the cavity is opened back up, okay? In this scenario, we would go over, oh, there's scar on this left side. We would just cut this band, maybe remove a little bit of the scar, and then what's left is this. And now this person's cavity is normalized, okay? Whereas prior, this was completely obliterated. You couldn't see over here. That can take 20 minutes. That can take 60 minutes. Sometimes there's scar on our way in. So again, that's why the preoperative imaging is critical in setting expectations of how the surgery is going to go. I often tell patients prepare for multiple hysteroscopies. At the minimum 2, because the first one is the treatment, and then the second one is the confirmation that there's nothing, no reformation of scar. Because again, remember, when we cut this space, it's now a potential space because this is tissue that's not supposed to be there. So when the uterine cavity collapses, these raw surfaces can touch each other again and that scar can reform. So oftentimes we do a second hysteroscopy, maybe in the office, maybe in the operating room. If it's not severe, we'll just do a saline study again just to document that this is opened back up again. If it's closed, we go back in, repair it, okay? Now, there are adjuncts that are used post-operatively that I'll talk about in the cases of hysteroscopy in patients with Asherman syndrome. So oftentimes, at least this is what I do, there's variations of this, but just so you understand what an example of this looks like, you'll do a hysteroscopy, and here's a timeline. The hysteroscopy, let's say, is on July 1st. You will give the patient put a balloon inside the uterine cavity that sits here like this, that helps these raw surfaces, prevents these raw surfaces from touching each other. So it's almost like a mold that sits in the uterine cavity with a catheter that hangs out of the vagina. Well, that's a foreign body, so we give antibiotics. Now, there's some debate of whether this makes a difference or not, but somewhat ideologic. Some people like to keep this in. It makes everybody feel better, like we're doing something. I don't think it's unreasonable to have the balloon, and it's largely used. we then add estrogen on top. So after you cut any scar, you want to see, I see some tissue, it's normal, it looks pink. Let's give high doses of estrogen so we can grow the grass around the scar, if you will, and that prevents these raw surfaces from touching. It almost acts as a buffer if you can grow the lining around any scar incision, any lysis of adhesions that were performed. So we keep patients on estrogen for 3 weeks, and then we give them Provera with the start of the 3rd week, overlapping the estrogen with the Provera, and then we wait for a period. If these patients never had periods and then they do have periods after the surgery in response to the high dose of estrogen, that's a good sign that they are recovering. We then repeat the hysteroscopy, and if everything looks good, we let them move on to whatever their goals are. If there's still scar and we have to do this again, we then do the same regimen again, okay, where we put the balloon in, give them estrogen, and then we might do 3 or 4 hysteroscopies. If we're doing more hysteroscopies, that means we're not making much progress and this scar is reforming, in which case we say, hey, it is what it is. You have an entirely open left side, you're fine, tube is fine, or hey, we gave it our go. This is the limit to what we can do. It's been 4 months. We need to try to move on to other things. And maybe if the entire cavity is obliterated, that might mean we're moving on to a gestational carrier. So the approach to Asherman syndrome is usually serial hysteroscopies until resolution of the cavity, which can take 3 to 4 months from start to conclusion. So the journey, everything's a journey in reproductive medicine. There's the fertility journey, there's the IVF journey. There's a journey associated with surgical correction of Asherman syndrome, and it's usually serial hysteroscopies over the course of 2 to 4 months. Again, talk to your doctor. Everyone's approach is a little bit different. And again, it's a function of the significant diversity of severity that comes with Asherman syndrome, from just the very minor synechiae to the completely obliterated cavity. So keep in mind that there are lots of options available. It makes sense always to do hysteroscopy to understand and assess and treat. But at some point, there are limits to what can be corrected depending on the severity of the disease. Talk to your doctor, talk to many REIs do a lot of complex hysteroscopy for this procedure. Oftentimes you can have scarring here, and where the upper part of the cavity is completely normal, but the lower part of the cavity and the cervix is problematic. Maybe there was a perforation, maybe there was from a prior surgery, from a prior DNC. We are very used to finding our way into a uterine cavity, navigating through scar. We usually use ultrasound guidance to do these things. So again, this is more complex hysteroscopy than just the simple hysteroscopy that many gynecologists are comfortable with. So if you have any questions about it, talk to your gynecologist, see a reproductive endocrinologist like myself, and know that there is a viable treatment path for you. All right. Again, thank you. This is the Asherman series. This is the one on treatment. I hope these have been helpful. Thanks for watching.